Each year, more than 795,000 Americans suffer a stroke. That means someone in America, United States, has a stroke about every 40 seconds. Strokes, also called brain attacks, are the fourth leading cause of death in the United States and the second most common cause of death in the world. Sadly, stroke is the number one cause of disability in patients over 40 in the United States. In addition, it accounts for about $73 billion in cost due to lost jobs, rehabilitation, and secondary complications. The good news is that if a stroke does occur, we have new treatment options that will allow us to reduce or eliminate some of these serious outcomes. A stroke occurs when a blood vessel that carries oxygen or nutrients to parts of the brain actually become blocked or start to leak blood itself. When this occurs, that part of the brain, that brain tissue, actually starts to die. Because time is so important when a patient arrives in the emergency department with signs or symptoms of stroke, we have to act quickly to determine what type of stroke they're actually having, because that can determine what sort of treatments we'll be able to offer the patient. The majority of strokes, up to 85%, are caused by a blockage of the blood vessel. These are called ischemic strokes. With ischemic strokes, we have a short window, about 4.5 hours, when we can actually give a patient an IV medication, a clot-busting drug called TPA. That will allow us to be able to open up that blood vessel in a very rapid fashion. Beyond the 4.5 hour window, there are some newer treatment options that in some cases can really help a patient. These include using catheters or devices to be able to go in and retrieve the clot out of the blood vessel and open up the blood vessel again to supply blood and nutrients to that part of the brain. To be able to receive this timely treatment for a brain attack, it is important that you or someone near you acts fast and dials 911 to access the local emergency medical system.
That morning I got up really early to take my granddaughter to school. I did take her to school. I came back. On my way home, I stopped at Home Depot and got a basket of yellow chrysanthemums and put them on the front porch, came inside, my phone rang, which it usually does every morning. It was my daughter in Houston. I just felt so terribly disoriented, and the talking, I knew my speech was off. And she said, "Mom, you're talking terribly. Something's wrong. I'm going to call 911. And I said, "Oh no, Alita, don't call 911. She said, "Yes, Mom, I'm going to call." So she did call, thank goodness. And it wasn't long before the EMT fellows were there. The doctor started talking about a TPA. And of course, it was very confusing because, they kept saying, "Why are you looking over to the left? Look over to the right." Well, I didn't realize what was going on. But my daughter and her husband told me that they thought it was a good chance to get the TPA, go ahead and do it. So I did, and after testing, CAT scans and MRIs, then they put me on a helicopter, and Dr. Janardhan did the surgery, saved my life, and I understand that I was awake during surgery. I remember a little bit where they told me to wiggle my toes and fingers, and I did that, and afterwards, they took me to ICU. I was so lucky because I had the TPA first. That gave me a chance to have the surgery. The helicopter ride gave me a chance to have the surgery because I got to the hospital in time within a certain time frame. If you don't, your chances of survival are slim.
So when you're trying to determine a patient who's going to be able to qualify for endovascular rescue, some of the things you need to know are the last known normal time. You need to know what their NIH stroke scale is, because you want to know what the severity of the stroke is. Usually we're looking for a stroke scale that's above 10, and that lets you know that there's something there that's probably a large vessel occlusion. Another way you can check for the large vessel occlusion is that you can do a CT scan or a CTA or MRA, and that'll let you see if there's a large vessel occlusion on those images. The other thing you want to look for is you want to look to see if there's actually tissue that's salvageable. So one of the ways we do that is we get either a CT perfusion or an MR perfusion. Now with the advancements in endovascular therapy, one of the things we can do is we can expand the time window past the 4.5 hours for IV TPA. So when you have a patient that is able to come in and get one of these therapies, the first thing you want to do is find the last known normal time, as I said previously. Once that happens, the advancements and the newer types of neuroimaging that we have are valuable. So here on the screen I have is an MRI which shows an acute stroke in the bright area. This is the diffusion image, and that allows us to see what areas are already dead. Then we can take that and we can combine that with the diffusion image, and we can also say what images are allowed there that are not dead but are still able to be salvageable. And that helps us determine what patients are going to be categorized into those that we can bring into the angio suite, and then we can actually go in and do endovascular rescue.
Brain attack is nothing but a heart attack of the brain. And like we've had amazing developments in the field of heart attacks in the last couple of decades with balloon angioplasty and stenting as minimally invasive therapies for the heart, we are now in that exciting phase for brain attacks where we have new exciting therapies to be able to open up blocked brain blood vessels just like we used to do for the heart blood vessels. When a patient presents with a brain attack, they have a blocked blood vessels inside the brain. We need to go in to open up that blocked blood vessel. This is an example of an angiogram in the cath lab where we do it, and we find the carotid artery is flowing well over here, but there's an occlusion, there's a clot in the middle cerebral artery, an important blood vessel going to the brain. And you do not see any blood flow inside the brain blood vessels out here, which is completely at risk for dying. We have different techniques to do that, and it's constantly evolving, and we have newer and newer therapies that come out every day. Some of the therapies that we have are like a wine bottle opener, and it's a corkscrew-like device that we place around the clot, and we're able to then entangle the clot and pull out the blood clot. In addition, we've got vacuum suction devices, which are like a vacuum hose. It's just very tiny, and we take it up to the blood clot and we try to aspirate the blood clot. Once we use endovascular therapies to open up blood vessels, what we find is that we are able to pull out these blood clots or aspirate these blood clots, and we're able to restore blood flow in the middle cerebral artery. And now you see the complete middle cerebral artery has opened up, and there's good brain blood flow in the area that was risk at dying. So this is how we salvage the brain and help people with blockage type strokes, and it's a real exciting time ahead for us. But the key thing is for patients as well as families and everyone in our communities to understand the signs and symptoms of brain attacks and seek medical care quickly.
My daughter has a friend in Oklahoma, and she talked with her. She's a nurse, and she said, if I had been in Oklahoma when this happened, I would be dead, because they don't have anything like this. You know, all communities need services that you can follow through and get you to, you know, a stroke center. It's tragic and it turns your life upside down. It's going to be a positive in my life. With our community centers, with our hospitals, with all the help that is out there, I'm alive today.